When you look at COVID-19 and the fact that certain people, A, are just fed up with restrictions or lockdowns, what can you tell them about the number of hospitals in the U.S. but elsewhere that just cannot cope with the number of sick arriving?
This is starting to tick up, and there are multiple states in the United States, including Wisconsin, both North and South Dakota, as well as Utah and parts of Texas, where hospitals are unable to cope with the number of patients that they're getting. And what that means is that not only will they have to deal with a lot of COVID patients, but that impacts all their other operations, meaning their heart attack care, their trauma care, and that makes everybody's health go down. So the key thing is, even if you have pandemic fatigue, the hospitals still have to take care of patients with COVID, and we want to make sure. That's what bending the curve was all about, or flattening the curve, was trying to keep it below hospital capacity. And sadly, many places in this country do not have the capacity to deal with these cases. And the same is true in Europe, for example, and that's when you see public health interventions being made. So our goal is not to get the cases to zero. That's really impossible. It's to keep them to a pace that's manageable by the healthcare system. And in order to do that, that's the common sense recommendations that you keep hearing about, as well as a plan for testing, tracing, and isolating.
The people that are packing hospitals, and of course El Paso, Amesh, is taking the headlines here, terrific challenges on the southern border with Mexico. The people in the hospital, how sick are they? As a general statement, obviously they've got the virus, obviously they're ill, but how ill is ill for a typical hospitalization?
A typical hospitalization involves usually somebody that doesn't necessarily need to go to the intensive care unit, but requires oxygen, maybe through nasal cannulas or maybe through a different type of delivery mechanism. So they're sick enough that they can't cope at home, meaning that they need to be in the hospital to be monitored, to watched, because some of those people do get worse and end up in the ICU. I would say in October of 2020, the average patient in the hospital is less sick than in March of 2020. We are getting better at taking care of these patients and intervening earlier so they don't get as sick, and people are probably getting infected with less virus because there's so much social distancing, so much facial covering use, that what we call the inoculum is lower. This is a hypothesis that needs to be worked out, but it does seem that they're less sick. But that doesn't mean that we're still not getting over 1,000 people dying, that this still isn't a deadly disease that we have to take very, very seriously.
If someone's had the virus in March, April, May, June, if you catch it again, is it going to be less worse than the first time, Amesh? And overall, you talk about the viral load. Is it also because it's a different kind of population that's now being hit that we're seeing less hospitalizations?
It's a little bit of both. So reinfections are very rare. There's only been about a handful documented, so we can't really say whether or not when reinfection occurs, whether it's worse or whether it's not worse. With other coronaviruses, it's usually very mild when you get reinfected, but there has been at least one case where it was worse with this coronavirus. But again, this is something that we only have very small numbers, so you cannot make any kind of real scientific statement about it. It is true that the demographics of the pandemic has changed. We are seeing younger people be more infected, and that makes sense because they tend to be more risk tolerant. They're the ones that are going to taking part in sports, for example. They're the ones doing small gatherings, and vulnerable populations are still sheltering in place a little bit more to a bigger degree than younger populations. And younger populations are generally not those that are going to need hospitalization. So that is somewhat skewing some of the data because the demographics have changed. But it is true, though, that there are vulnerable populations that are still getting infected, and they are the ones that are in the hospital. They are the ones in the ICU, and they are the ones dying.
So vaccine trials have resumed. How quickly can we actually get a vaccine that can be distributed and used by a good chunk of the population?
For a good chunk of the population to be able to get a vaccine, it's likely going to be mid-2021. At the best case scenario, we might have an emergency use authorization for one of the vaccines prior to the end of the year, but that's really only going to allow it to trickle out to healthcare workers and maybe some high-risk individuals. You have to think about the scale of getting enough doses of the vaccine available to meaningfully impact the virus. That's a long time, and this is going to be a 2-dose vaccine with a lot of logistical challenges because it needs to be kept at a very cold temperature. So I do think we're going to be battling this virus without a vaccine well into 2021.